So I farm so hard, the employees wanna find me, and then wanna hire me. What's 100K to a guy like me? Could you please remind me? Farm so hard, this ain't easy. Working late nights, you best believe me. My grades can only go A's. Never wanna see another B unless I'm Jay-Z.
What's good, fam? It's Jim Pruitt, aka Farm D and the ED, and I'm bringing you another episode of the Farm So Hard podcast. This is going to be another phenomenal episode, and we got some friendly faces on here, some familiar faces on here, and we have one of the smartest MICU pharmacists in the world joining us today. We're going to be talking about something that is pretty intriguing, and it's something that you probably are doing if you're a part of Cool Kids, or you want to do. You just haven't made it part of your recommendation pathway yet. DKA. We all see it. We see the patient in the ED. They go to the MICU. They clog up your beds for probably a full day. Then they walk out like nothing ever happened to them. We're going to be talking about the long-acting insulin up front. Should we be doing this? Should we not? And what better way to talk about this but to bring on some people who actually did the study on this. So I'm going to go ahead and introduce my guests for this episode, Tessa and BG. So Tessa, go ahead and give them a little quick intro of yourself, and let's go ahead and jump into this episode.
Hi, my name is Tessa Cox, and I am a medical ICU pharmacist here at Wesley Medical Center in Wichita, Kansas. I did my PGY1 and PGY2 critical care residency here at Wesley. Stayed on here in the MICU and have been here since 2019. And go ahead, Brian.
Jimmy, first of all, thanks for having us, bud. Appreciate you. I mean, they're starting to rack up a little bit, but I appreciate you letting us come in and reflect on our research a little bit. Something near and dear to our hearts, and something that I will say was not born out of kindness. It really just was born on or based upon us all getting fired up and kind of mad that, like you said, these DKA patients, nothing against them. It's just that it's one of those things that could we be doing something more efficient? And so one of the dogmatic practices that we've always seen is, built around basal insulin. So happy to discuss it today. And hopefully it can be, like you said, part of the recommendation pathway here for pharmacists moving forward.
Perfect. And so for you guys listening, we're going to be going through just doing a brief overview. Then we're going to go into a study that was authored by our guest today and really just give some insights at the very end. So it's going to be a quick intro, get into the study, and then give our insights based off of this, because this is the episode that everyone can listen to. So whether you're a student that's going to be doing a topic discussion on this, you're going to get pimped on this. So you might as well know what the data says. Whether you're a resident or if you guys are PGY2s and ED or critical care, this is something that you're going to be involved with. And if you're practicing, you're tired of seeing these patients. So as far as not getting treated as appropriately as they possibly can, or you're just a EBM guideline and just guru, and you're just very sick of tiptoeing around the topic, this is going to be episode for you. So let's go ahead and jump very briefly into some background. Tessa, can you walk us through the definition and path, though, and just give us this really quick, 30-second overview?
Yeah, of course. So conveniently, like we've mentioned, the new diabetes guidelines have actually just been published this week, and their diagnosis criteria has updated slightly. Diabetes, DKA, diabetic ketoacidosis, has 3 diagnosis criteria that you want to look for. So hyperglycemia with a blood glucose greater than or equal to 200 or a history of diabetes. And this kind of comes from those patients that might come in with euglycemic DKA. Secondly, ketosis must be present. A beta hydroxybutyrate of greater than or equal to 3 with 2+ urine ketones or greater. And then the A for DKA, metabolic acidosis, so pH of less than 7.3 and or bicarb of less than 18. And DKA is going to present this triad of 3 things. So you're going to have your ketonemia with the presence of ketones. That's going to cause your metabolic acidosis with a hyperglycemia. This can occur in both type 1 and type 2 diabetics. And it is mainly caused by the deficiency of insulin and the increase in your counter-regulatory hormones. So that just creates this cascade of things, including increased lipolysis. So you have increased fatty acids, increased ketones, creating your ketonemia, ultimately leading to metabolic acidosis, the decreased glucose utilization, and increased counter-regulatory hormones, like I mentioned, causes your liver to increase its gluconeogenesis and glucogenolysis, therefore increasing your blood glucose, causing hyperglycemia. So again, back to those three main things: hyperglycemia, ketonemia, and metabolic acidosis.
All right, BG, how are we going to be managing these patients? Just a quick overview. How are we going to be managing these patients in a traditional sense?
Yeah, no, I mean, it goes back to pathophys. This is one of the easier what's wrong pathophysiology wise and how to correct. It's super intuitive and from that aspect. So oftentimes, obviously, these patients are going to be have so much glucose within the serum that they're going to become dehydrated, right? So to maintain sort of that homeostasis, a lot of the fluids will become intracellularly dehydrated. And so one of the first mainstays of therapy is going to be fluid resuscitation, like large volume resuscitation in these patients. So we won't get into which fluid to pick on this episode. Certainly a lot of people and a lot of MICU people may have their druthers of what you use, but for us EM folks, lactated ringers, saline, whatever you want to use for resuscitation. And then, like Tessa said, it's either having to do with the insulin deficiency or insensitivity to insulin. So in that setting, you're going to go ahead and replace that. So historically, what we've done for most part has been start these patients on IV or intravenous insulin infusions with either set rates where you titrate fluids or fluids with titration of the insulin itself. Also another episode that you could probably do, but we won't get into that as well in terms of total insulin IV management. There's been newer guidelines that have actually come out that have looked at for some of these mild to moderate cases. And most people, when you get into practice, you'll know that there's these really like these 1-day ICU folks that walk in and out and then they're gone within probably 48 hours. There's some of these patients that are a little bit sicker, but still not that acutely ill that they can't walk out within like 48 hours. And then you have some of your really sick patients that DKA is just a side process of what's going on because of their acute illness, whether that's an infection or something else that's going on. But some of those mild to moderate cases, you can actually utilize sub-Q insulin only. Now, this is one of those like academic prestige things that seems really nice on paper, but for us community folks that maybe potentially don't have the same type of resources, including, physician personnel, even lodging, right? So like having an ICU resuscitation area within your ED to allow these patients to just be resuscitated with fluids and sub-Q insulin. That's one of those like pipe dream type things and aspirational type approaches. The big thing and the thing we're talking about for this episode is basal insulin. So historically and dogmatically, what's been preached to probably all of us when we were being taught DKA and probably still being taught in a lot of centers, including medical and pharmacy, is that you give these patients IV insulin, you wait until their gap closes, potentially even if they're sick enough, letting their bicarb normalize as well. And then you overlap IV insulin with basal insulin for 1 to 2 hours, which is actually recommended by the new guidelines that just came out on the 22nd as well, right? So definitely nothing wrong with that. You definitely need to have some overlap. The problem is what Tessa and I would argue is when you actually need to give that basal insulin. Historically, what's been taught is that you wait until the gap closes, then give the long-acting basal insulin, and then allow for 2 hours of overlap. What Tessa and I say is, hell no, don't wait. Just go ahead and give it. Go ahead and start the basal insulin because as soon as you have resuscitated the patient, the gap is closed, and it's been 1 to 2 hours. Usually it takes upwards of 4 to 6 to 8 hours for those mild to moderate cases, is then you can just stop the insulin drip, usually downgrade care, get them something to eat, and then potentially get them out of the hospital. JP, you've seen this in your hospital, is when you're boarding these patients, especially when they're not going to go anywhere for 12 to maybe even 24, 48 hours, is you can redo all that within your ED. You don't have to wait on any of that. So starting it earlier really started at our institution when we started having a huge amount of boarding, usually right before COVID, we started talking about it, but definitely during COVID is when we really started to look at is this a process we should be doing? So we went to the literature, started looking at it, and there's quite a bit of literature. It's all single center, but mainly the thing that most physicians and everybody wants to know is this a safe practice? So given insulin, one of the things you worry about is obviously hypoglycemic events. So were these patients getting hypoglycemic? And then secondly is shifting of potassium. If you're giving IV insulin and you've given basal insulin, you want to prevent any sort of hypokalemic events. So one of the things that we looked at was is this a safe practice in our institution? So we did a pilot study. One of our PGY2s looked at this and did MUE, just to essentially say, is this a safe thing that we could be doing? Because anecdotally, what we found is that when we did do this process, patients were leaving the hospital quicker. And some of the patients in those mild to moderate ranges, we were able to resuscitate and get them out the door that day. So that's a brief, succinct way of saying how we essentially manage it, where the basal insulin started, and kind of where some of this study idea started.
And that's gonna be great because getting kind of the background as we jump into this, and shout out to Danielle and everyone that's been part of this particular study. But Tessa, I really want to jump into some of the kind of the design of a lot of this, and then really hit some of the things that people are going to be asking, like, oh, was this a randomized control? Like, what was this on paper from the method standpoint? And then BG, we're gonna jump into the results after that.
We took a couple years worth of our data when we kind of went back far enough to where we knew this was a practice that we kind of started implementing and getting involved with, especially with our emergency medicine pharmacists, including Brian, and just included all the patients that met our inclusion criteria that had received subQ basal insulin prior to anion gap closure. And we did decide to exclude a few patients, our severe DKA patients, just to try to limit some confounders in that group. And our primary outcome for the study was hospital length of stay. Secondary outcomes we included were ICU length of stay, duration of IV infusions, and time to anion gap closure, as well as incidence of rebound hyperglycemia. And then for some safety outcomes, we looked at incidences of hypoglycemia, which we defined as a glucose less than 75, and then also looked at severe hypoglycemia, defined as a glucose less than 60.
Perfect. Now, BG, based off all this, we kind of extracted all this data for years and years and years. And again, you said years of patient reports. I'm thinking like, crap, how long did it take you to actually pull and analyze all that stuff? Based off pulling all this stuff, and based off of really, I know you guys did a review article this in October. I know there's been a lot of information been coming out your shop about this. And with all of this stuff, what did you guys actually find? And give us some kind of caveats to everything.
Yeah, no, I like you said, it's been a long time coming. So two big shout outs was, first, we did the MUE with Caitlin Tabaka, who was our PGY2 at the time. She found this was safe, so we kept trekking forward with it. So big shout out to Caitlin Tabaka. And then the biggest shout out of all is like you said earlier, to Danielle Murray, Dr. Danielle. She just got married, so I'll use her maiden name because that's what is in the paper. But she put together and found and did this study. This was her PGY1 residency research project. So she did a lot of the legwork on this. So big shout out. She couldn't be with us today, so unfortunately, she'll give you a better insight than probably us. But what we found essentially was one of the things we wanted to set out for is looking at length of stay. To again look at one of those hard patient outcomes that we could potentially affect as pharmacists, because this was an intervention that was not occurring unless emergency medicine or critical care pharmacists were making it. So essentially, the ED folks or our ICU overnights or Tessa making those recommendations. And so that's kind of why we ended up limiting to just mild to moderate DKAs, because our severe DKAs, obviously, we talked about they're going to be more so, they're going to have more confounders or reasons that they're going to stay longer. So that was one of the reasons and rationales for limiting it to just for that. Now, in practice, we do still do it with our severe DKAs. and I'm just trying to give a quick overview on that. But overall, what we found was our length of stay was not statistically different between those that received early basal insulin and those that did not receive early basal insulin. For the average length of stay, it was 62 hours for our basal insulin folks, and then 71 hours for our non-basal insulin folks. We had about 100 patients, 40 patients were in the early group and 60-ish in the non-early. Now, certainly not a huge study, but certainly not a smaller study in comparison of the cohort we're looking at. So we were a little disappointed not to find a difference, but overall, when you look at like a 9-hour clinical difference, I'm not trying to advocate that since we didn't find a statistical difference, there's no clinical meaning to it. You could make the argument that 9 hours is clinically meaningful for patients, especially when you're boarding. One of the things to think about is that with these patients, if you're not having to spend the resources on them, there's other patients that may still be receiving this. So those are things that are hard to capture in a retrospective study, and especially looking at patients outside of the cohort. So we did not find a difference. But what we did also find was that the practice was still safe. There was no higher incidences of hypoglycemic or hypokalemic events. And then other length of stays were obviously the same as well, like with ICU and whatnot. So again, depending on how you look at it, it's either a negative study and we're just going to keep doing our practice the way we've been doing it, or at least interesting and an aspect that potentially could look at, a larger multi-center retrospective study to evaluate this practice. To date, I'm not aware of any multi-center site studies that have looked at this. You talked about our review. Thanks for that shout out on that review from October. When we put together that was essentially that was born out of frustration and anger as well. We wrote that because we kept getting asked why we're doing this practice, and we tried to show them and demonstrate that the data that was there to do this practice. And so we just compiled all of the evidence together and then sent it out to our learners and to our medical staff. But yeah, so overall, we were pretty happy with the fact that we didn't have any adverse events associated with our practice. So we're going to still continue to do it. A little disappointed that we didn't find a statistical difference in terms of our primary outcome. But again, it's easy to justify 9 hours clinically being extremely relevant.
Yeah,
probably just not powered to detect a difference.
That's the biggest thing, dude. It's like, tell my charge nurse in the ED that I can get a patient out of the MICU in 9 hours sooner. You think that's a shift difference? So I always think we have these beds that we're just waiting to get these patients out. We tube 10 patients, and it's like I would rather have that tube patient there versus the DKA patient,
or an outside facility transfer you can't take because you don't have room. So it seems like. Yeah, absolutely. Those type of things that are hard to monitor downstream. But again, a safe practice that is actually endorsed by the the joint European guidelines that aren't actually, well, I don't want to steal the thunder. We'll talk about the ADA here in a second.
So you got any additional comments on like just the results before we or just your interpretation of the results? I think from the ED perspective, we like that, but I know sometimes MICU is like, if it's not statistically significant, I can't say anything about it. You got any thoughts on that?
Yeah, I think I agree and echo everything Brian said. And I have a little more of that EM attitude, I guess. Maybe he's rubbed off on me a little bit. It is disappointing we didn't find a significant difference, but I do think 9 hours could definitely be clinically significant.
Perfect. And we look at all of this, and again, we keep harping on this thing over and over again. I think for residents and students listening, it's always tough to find the difference of a statistically significant thing versus something that's clinically. And I just think about, what does that mean in dollar signs to the C-suite? If we can put a price tag on the bed and we say that we're saving X amount of dollars per patient we do this on, and say we do this again as a multi-site study, and say Megan Reck and her crew just decide to get a 10,000 group, study that's done, I'm pretty sure they'll be able to find something with a little bit more resources and a bigger number. So I think a lot of this goes back and forth to saying, hey, we didn't find what we wanted, but again, we found something. And we also found that this was safe. And I think as clinical pharmacists in general and pharmacy altogether, the first thing, we make sure that something is safe before we recommend it. And then we can build off of that. And I think down the road, we may revisit this, and we may find some cost analysis studies. And you start getting to where the people in suits start to perk their eyes up when you say, hey, if we did this, and everyone has DKA patients. So if we look at all the DKA patients in your hospital all year, all of them, and we say we can save you 9 hours across the board, and just the mild to moderate ones, we're going to save. We can find something. So shout out to Danielle. Shout out to everyone else part of this. And really, that's kind of the big component of this study. But this was great, and I think this is phenomenal. We are very fortunate to be recording this the time that we did. I want to move to other guidelines that's been published and just some insight from you guys, because this was, I think, pretty intriguing. So BG, I can go with you first, and then Tessa, we can kind of go with you and just talk about the guidelines, this overall big picture things, and close the episode out.
Yeah, no, it's fortuitous that we did this. As I mentioned earlier, 3 days ago, the ADA released in a joint statement, essentially an update of what the consensus on hyperglycemic crisis management essentially looked at, which is a update from 2009. Been screaming at for forever that there has been zero update, and there's been quite a bit of literature, right? You could make an argument on early versus late basal insulin, fluid choice, rapid versus regular insulin. So there's been a lot of studies that they could have updated by now, but for whatever reason they didn't. And yeah, like I said, the European Society guidelines recommend early basal insulin. They're actually pretty aggressive. They recommend doing it as soon as you identify DKA within this patient, and they actually recommend dosing of 0.25 units per kilo with no max, which is kind of crazy, or the patient's home insulin dose. So I'm not that crazy. Oftentimes patients are unable to take their insulin outpatient. So I don't usually give like a no max, or I try to say no cap, because this generation uses that for something else. But, in terms of dosing, I usually will cap it at about 20 units, because it is a good start for most patients. The majority of patients will be fine. If you have somebody that's maybe slightly more insulin insensitive, then you could make the argument for higher doses. For me, that's not part of my practice yet. But yeah, this ADA statement comes out, and basically they do say, hey, you need to overlap basal insulin and IV insulin for 1 to 2 hours. But I call them cowards. They're absolutely cowards. They don't say when to do it. They don't say do it right away as soon as you identify DKA. And so, there's data that suggests out of St. Luke's and Kansas City, Missouri, that for every 6-hour delay in administration, or for every hour delay of basal insulin, there's a 6-hour delay in anion gap closure. So wow. Give the damn insulin. There's nothing to stop you. It's a safe practice. Sorry, I'm off my soapbox.
That's what you got.
Yeah, I agree. I mean, I'm not quite as involved with, figuring out the basal insulin dose and stuff like Brian is in the ER, but as soon as they get up to the ICU, if they haven't had some long-acting insulin, we're evaluating them for that for sure. It just, kinetically with the way the long-acting insulin works, it just makes sense, from my opinion, to get that basal insulin going, especially in patients that we know have a history of diabetes and are on basal insulin at home. I did also kind of find it interesting that the guidelines seem to kind of be moving away from anion gap closure as the end all be all for transitioning off the IV insulin. So I think maybe that can also help us out with determining or, advocating for giving that long-acting insulin earlier in DKA.
This is unique because I think we've all seen those patients at the very end of their DKA where you're looking at them, they're looking at you, they're sitting in the bed, the nurse is like, hey, fam, what are we doing? But that anion gap is not exactly, depends on your hospital, 12 or 15 or whatever the exact number is, like 15.5. And it's like, oh, fam, I got to do 3 more hours on the insulin drip in the unit. So I think we're getting there. But
it's the Apple test. If they're able to text on your phone, then you need to get the hell out the ICU.
Oh my God. They need to go. It's like they're sitting there playing like Candy Crush and just chilling out. It's like, what are we doing, man?
And Candy Crush is what got them into the DKA to start with.
But I think it's really pretty cool. I don't want to go too long. This is a great episode. And just to kind of recap a lot of this, they did a great study looking at about 100 or so patients in the ED and within the mild to moderate group of patients started in ED and gave them long-acting insulin. And they didn't find any statistically significant difference, but 9 hours was the difference between their early versus traditional basal insulin group. To me, I think that's clinically significant. I think to my boss, if I can calculate that number per patient that I see in this thing, I think it's going to be significant. But it's something that we have to kind of take away, and realizing the guidelines updated, they gave a very weak recommendation when compared to our British colleagues. So I think it's something to really wrap our head around and say, realistically, this is going to be something I always say in 2 to 5 years, we're going to see a big practice change, but we may not get a guideline until I retire. So you never know. We go from 2009 to 2014. Tessa, just to wrap us up, anything you want to mention as part of your closing thoughts?
I would just say if you guys are considering using long-acting insulin and want to try to decrease your length of stay in the hospital and the ICU, and so far all the data we have is shown that it's pretty safe practice. So definitely consider utilizing long-acting insulin in your patients who come into the hospital with DKA.
All right, thanks, Tessa. BG, got anything?
Yeah, just shout out to Danielle again for a wonderful project. She crushed it and did a good service for patients at our facility, but hopefully have done a great service for other facilities that are considered doing this. And not to have a shameless plug, but if you're looking at data beyond just ours, take a peek at that review that we did in October in American Journal of Emergency Medicine. We compiled it as much as we could. That seems to be pretty accurate, other than our study that we just did. So it seems like that's all the evidence that we have together. It seems like a safe practice. And so thanks for having us again, man. This is we're gonna have to keep pumping out the research just so we can come out and hang out with you.
Well, thank you guys for coming on. It's always unique to be able to actually speak to the people doing the research and make it more human. I think one thing that comes up, especially within pharmacy, is that when you see someone publishing a lot, you think they're just these people who can't be touched, and you don't get to see their minds. And I like to show kind of the personalities, especially as we're doing like this EM lit series and really just highlighting the work of EM pharmacists across the board, no matter if you're academic, no matter if you're community, no matter what it is. We just want to make sure that good work is getting pushed out there, and we can put a face to the name in all the publications. So I thank both of you for coming on. Shout out to Danielle. Shout out to everyone who's part of this study. I'm going to put the study for this one and a review article in the show notes, so you guys can be able to click on that very quickly. And usually I can have it set to where even if you're on your phone, you can just click that link to the PubMed and get you straight there. So we're going to put that in there. But guys, I close every episode out the same way every single time. You don't have to be a pharmacist. You got to work in the ED, but everything you do, make sure you farm so hard.
Closes it. Ozzy scratches his head. Whatever she's looking for, it isn't in there.